So I apologize for not finishing all of the rounds this morning, but I did add in some extra videos, so hopefully that makes it at least a little bit worthwhile. But I'll start with case 3. Again, if you have questions about case 1 or 2, please let me know. Case 3 is a 3-year-old male-neutered pug with a 1-year history of seizures. The patient has been on phenobarbital, Keppra, zonisamide, and potassium bromide, and the patient presents to you with a recent onset of cluster seizures. He has had approximately 18 seizures in the last 24 hours. On presentation, the patient is severely obtunded to stuporous. The exam is limited, but you do get an absent proprioceptive placement in the left and delayed placement in the right limb, so both thoracic and pelvic. Oculocephalic reflex is absent bilaterally. Vision and PLR were not assessed because the patient unfortunately started having a seizure during the exam. So this one will be kind of brief as far as things we talk about. So when you have a case such as this, some of the other questions you would want to ask the owner would be, has he been receiving the medications correctly? Have drug levels been looked at? You can definitely look at those for phenobarbital and potassium bromide. Make sure that the patient has not gotten into any sort of a toxin, which in this case there were no known toxins. Make sure there's no history of trauma or anything like that. See if there's been any sort of unusual behavior as well before leading up to these seizures. The next thing would be, what do you recommend for the owner? And so ideally in this scenario, you should be concerned that this is not idiopathic epilepsy. Some of the changes that we're seeing, although they could be post-ictal, patients being stuporous or having absent oculocephalic reflexes, that would not fit with just idiopathic epilepsy. And also being a pug, that's not one of the breeds that we typically think of with idiopathic epilepsy. They get something much worse that ends up causing seizures, which is what this patient had. So as far as recommendations, ideally referral and MRI for this patient. If they can't do that, then trying to control the seizures as best they can, getting drug levels, seeing if you're within the therapeutic range for the medication. And because idiopathic epilepsy is likely not the first differential in this patient, you could start them on steroid therapy. You just have to be sure to talk to the owners the cons of doing that, the side effects with giving steroids, and that if this is some sort of meningoencephalitis of unknown etiology, in pugs, the most common form is necrotizing, which this pug unfortunately had, so this is his MRI. And if you look at the transverse, you can see in the right cerebral hemisphere, so remember when we're looking at radiographs, MRI, CT, it's always a mirror image. So in the right cerebral hemisphere, we can see dilation of the lateral ventricle, and within the cerebral cortex, localized mainly to the gray matter, there's a pretty strong hyperintensity present, and this is consistent with a dog who has necrosis in an area of the brain, and it's filled in with fluid. So now this is cerebrospinal fluid, and the reason why that lateral ventricle is dilated is because there's less cerebral cortex on that side, and so it's compensating for the amount of neuronal loss. The other question was, what treatment would you recommend for this patient immediately? And that would either be a benzodiazepine, and then if that didn't work, giving propofol, and then likely putting this patient on a CRI. And then the last was, what do you think the underlying cause is? And we discussed that here, that it unlikely to be just idiopathic epilepsy given those deficits. Some toxins can cause that, although most would not cause the absent oculocephalic reflex. So some sort of structural disease should be the first thing on your, as far as your differentials. So case 4 is, I'll leave it up there for a moment so you can pause the video if you want to read through the whole thing. But basically, this is a 13-week-old female golden doodle who was dropped on her head, and we're suspicious of a traumatic brain injury. So read through this. The first thing that I want you to try to answer is, where do you localize? And then what modified Glasgow Coma score would you give this patient? Then based on that score, what is the prognosis? So if you want to pause here, read through that, and then you can come up with a score and also where you would localize. Now think about what you would like to do for the patient as well. So just as a reference, I'll put this up here on the screen for a modified Glasgow Coma score. Something to note in this patient is when you're looking at pupil size, normal is obviously going to be kind of a mid-range pupil size. If you have meiosis bilaterally, so pinpoint pupils, that's going to be consistent that there's sympathetic nucleus dysfunction. So likely some sort of problem within the level of the thalamus. However, when you get either asymmetrical or mydriasis, that's going to be concerned that there's a midbrain problem, so parasympathetic nucleus dysfunction. And that's considered to have a worse prognosis. And if you look back to the modified Glasgow Coma score, you can see that. So if this patient presents to you and you're wanting to control the seizures, it's perfectly reasonable to give it diazepam. But you should also be thinking about giving some sort of osmotic agent to help with increased intracranial pressure. Now, there is some debate that if you give something like mannitol and there's cerebral hemorrhage, that the mannitol could actually pool into that area, draw more water into it, or more fluid into it, and then that could cause worsening of the clinical signs. And although it does make sense in theory that that could happen, it's never been proven clinically. And time again, especially in people, they show that either giving mannitol or hypertonic saline in patients with traumatic brain injury is helpful. As far as which one to give, if a patient is hypotensive or they've just suffered a pretty severe injury, I typically start with hypertonic saline, just because mannitol can cause more electrolyte abnormalities and lead to more dehydration. And based on a recent study, there doesn't seem to be a difference in how well these drop the intracranial pressure. So both of them seem to work equally as well. And as best we can tell, they seem to last just as long. So for most instances, especially in cats, I give hypertonic saline. There are times to where I'll start with hypertonic saline and then follow up with mannitol after I get blood work, just because in theory it should have a longer duration of action. But again, not necessarily. In very severe cases, we actually will give mannitol CRIs, and that's something that's documented more so in people. Although you can definitely do that, make sure someone on neurology is involved before going to that extreme, because those patients can definitely get pretty significant electrolyte abnormalities. Another thing to keep in mind is that seizures are not uncommon following severe traumatic brain injury. So most of the time, we will give Keppra to these patients if they've had seizures following traumatic brain injury. If they have not had any seizures, we usually do not start Keppra. We usually wait until they've had seizures. There's some people that put all patients that have traumatic brain injury on Keppra. It's not wrong to do it. It's just you always have to think about owner compliance when you're doing things, and is this something that the owner is going to be able to do? So as a general rule, what I say, if they were not having seizures, then I don't give an anti-epileptic. But again, it's not wrong to do with Keppra. It seems to be a pretty safe medication. And then also as a general rule, we do not give corticosteroids. So no dexamethasone, no solumedrol, no prednisone to these patients. A lot of that comes from what we know in people, to where people with traumatic brain injury that receive corticosteroids tend to have a worse prognosis and have a higher chance of dying. We don't have any information in dogs as far as if they're beneficial or not. So based on what we know in people and some of the studies done in rodents, we recommend not giving corticosteroids to these patients. So in this dog, we ended up doing a CT scan. So you can definitely do MRI in these patients, but most of the time when we have a patient with traumatic brain injury, we want to answer the question, do they need surgery or not? And we can answer that question with CT. So on the left is a transverse CT, and if you look at the left temporal bone, you can see that there is a fracture, and that's highlighted better by the 3D rendering on the right. So you can see how there's this linear fracture, but there's no depression. So there's no bone fragments within the brain, and there's also no subdural hematoma. So those are conditions to where we would do a craniotomy to either remove a piece of bone that's compressing the brain, or if there's hemorrhage that is compressing the brain. You can see in that left cerebral hemisphere that there's this increased opacity, this hyperattenuation, that is indicative of hemorrhage. So the dog did have either a contusion or some sort of intraparenchymal hemorrhage that has occurred. That's not anything that you would treat though surgically. That's just something that you have to give them supportive care, control the seizures, and over time this will improve. They might have residual deficits long term, but again, this is not anything that surgery is going to correct. Most of the time with traumatic brain injuries, they're not the most stable patients, so we don't want to do a long MRI procedure. So a lot of times we just do a CT, answer the question, do they need surgery? If not, then we wake them up afterwards. The next patient is a 2-year-old castrated male Great Pyrenees that the owners found unresponsive outside. He was normal the previous evening. The patient does have free range on the owner's property, which is next to a cattle farm. The cattle were dewormed the day prior. On exam, the patient is found to be laterally recumbent and unresponsive. Its vital parameters are within normal limits. Mucous membranes are pink and tacky. Body condition score is normal. The rest of the exam is pretty normal as far as physical exam. On neurologic exam, the PLRs were absent and the pupils were dilated with elevation of the third eyelid. Before the exam could be finished, the patient started having a tonic-clonic seizure. So then the question is, what do you think is the underlying cause of the epileptic seizure? What would you give this patient to stop the epileptic seizure? And then what do you do to treat this patient after the epileptic seizure is controlled? Given that this dog has possible ivermectin exposure, I would suspect that this is an ivermectin toxicity. The way that ivermectin works is by binding to glutamate-gated chloride channels. And so when ivermectin binds to that, it causes an increased influx of chloride ions, and this ultimately leads to hyperpolarization of the nerve or muscle cells. Because although this doesn't bind to the GABA chloride channels, it binds to the glutamate-associated chloride channels, there is some concern that giving a benzodiazepine could actually make the symptoms worse. And if there is starting to become neurologic damage, that it could potentially make some of the neurologic damage worse because more chloride will be flowing into the cell after you give diazepam without negating the effects of glutamate. So most of the time, if you know that it's an ivermectin toxicity, you would give propofol. And part of the reason for that is because propofol itself is within a lipid solution. So ivermectin is lipid soluble, which is why it causes neurologic signs when there's toxicity. So if you're giving propofol, which is in a lipid solution, the thought is that that lipid could bind some of the free ivermectin that's still within the peripheral system and hopefully pull out some of the ivermectin that might be within the brain itself. However, the amount of lipid that is actually within propofol is pretty minimal, so that effect is going to be minimal as well. But again, the reason why, if you know it's ivermectin, you would typically give propofol is because it negates some of the effect of the glutamate being released. If you know that it is ivermectin, then something like Intralipic Emulsion is going to be recommended. It comes in a 20% solution, so this is the dose that you would give it at. And you give it over 90 minutes, you usually stop at that point and see what they do. If the signs start to come back, you might have to repeat this. There's not a great study as far as what the true intralipid therapy should be for ivermectin or for any toxicity for that matter, but this is a pretty standard protocol that's given. Remember, if you're giving intralipid emulsion, it has to be handled sterilely because it can get contaminated pretty easily. And you can give this through a normal catheter. You don't have to place a central line in order to give intralipid emulsion. But these images are from a patient that had ivermectin toxicity, and you can see that there's edema and vascular damage on the image on the left. And then after the lipid therapy, you can see how there's resolution of that edema and how the vasculature looks more normal now. Okay, so for our next case, it's a 7-year-old spayed female Pekingese that presented to the emergency service for uncontrolled seizures. She has had 6 seizures within the last 24 hours. She has not been normal between these episodes. She has become increasingly lethargic and weak. This patient has severe skin and ear allergies, which have been treated with Apoquil without much success. On recent blood work, she was diagnosed with hypothyroidism. The patient is currently on Ciplasef, ketoconazole, sucralfate, omeprazole, Apoquil, levothyroxine, and gabapentin. On physical exam, other than some of the integument stuff, it's pretty unremarkable. She does have a grade 2 out of 6 left apical systolic heart murmur. As far as our nervous system, we do see that there's a slight head turn to the right. Conscious proprioceptive deficits are present, but they're more severe on the left side, and that's both thoracic and pelvic. An abdominal ultrasound was performed on this patient, but there was no obvious abnormalities noted. This patient did have a Big 4 performed, so that's where they get blood glucose, PCP total solids, and the BUN stick or the urea stick, which I'm not a fan of, but we do it. We found that the blood glucose was 43 milligrams per deciliter. She was slightly anemic, and then we also did a blood pressure, and it came back at 192 milligrams per deciliter. Sorry, 192 millimeters of mercury. I got paged and distracted. Okay, so for this patient, what is the most likely cause of the seizure, and what would you want to do next? So I don't have any more slides on this case, but I was hoping to have a discussion as far as what were things that stood out to you with that history that would make you suspicious that maybe this is not just idiopathic epilepsy. So one of them would be the age. She's 7 years old, so that's a little bit old for idiopathic epilepsy, although it can happen at any age. Another thing that would be concerning is the glucose. So having a glucose of 40 or within the 40s would be unusual to be secondary to the seizures. It is possible, but it just seems unusual. So I would be concerned that maybe the hypoglycemia is why this patient is having seizures. So something that should be on your mind is a possible insulinoma, and those patients will often hover around 40 to 60, and then if they get an insulin spike, then it can drop, and then that can lead to the seizures. Other things that you could be concerned about, again, we've just done a big four, but could the glucose be low because of lack of production? So is it possible that this patient could have hepatic encephalopathy? We didn't see any evidence to believe that there's liver issues on the ultrasound, but this patient should have blood work performed and potentially bile acids or pneumonia. And then the blood pressure should also be concerning to you because there's what's called hypertensive encephalopathy, to where patients with hypertension can develop cerebral edema, and that can ultimately lead to seizures. It can actually be a quite common presentation for patients with hypertensive encephalopathy. So those are things that you should be thinking about when you see that history. So this patient should have a more thorough workup, potentially repeating the blood pressures, but doing a urinalysis, doing blood work, and if all that comes back normal, then doing an MRI in this patient. If they're not able to do that and the rest of the blood work is normal and you can't find an underlying cause for the hypertension and it's repeatable, then you could treat them with amlodipine, because most of the time the clinical signs reverse pretty quickly when you get the blood pressure under control. So I just brought this case up just so that way it's important to look at the whole picture. Don't get tunnel vision thinking that, oh, maybe this is just idiopathic epilepsy, that there's a lot of red flags that are telling us it's probably not. So the final case is a 6-year-old female spayed quiche-hound, and I'll leave this up there for a minute so you can read through it. If you want to pause it now, you can. But the main reason why I included this case is because if you read through the history, there are some things that make you think maybe this is not a seizure or an epileptic seizure. So that's the first question. Was this an epileptic seizure? If not, what do you think it could be? And then what would be your recommendations for this patient? And if you suspect this is an epileptic seizure, what medication would you recommend? So I'll go through some things that can mimic epileptic seizures, and I have some videos to go through with that. The first thing that I'll talk about, though, is what the seizures actually look like. So you can have a focal epileptic seizure, a generalized epileptic seizure, and then a focal epileptic seizure that evolves to becoming generalized. So here's an example of a cat that's having a focal epileptic seizure. So you can see that the muscles on his head and face are twitching, that he's having some hypersalivation as well. It's hard to assess, is his behavior truly abnormal, but it looks like it might be a little bit abnormal. But there's no full convulsions. The body is not having the classic tonic-clonic type of epileptic seizure. Whereas here, I won't show the whole video because it is quite long, but this is a patient that has a focal epileptic seizure that progresses to being generalized. You can see he has a classic tonic-clonic type of event. So as far as things that can mimic seizures, we call those paroxysmal events. So I'll put up a video of a patient, and I just want you to think, what could this be? So if you want to rewatch it before seeing what it is, you can. But this is a patient that has syncope. So if you watch that patient in the beginning, you could see that there almost seemed to be a tonic-clonic type of event before the patient was fully just laterally recumbent and flaccid. So sometimes they can have movements with syncope, all syncope is implying is that there's decreased blood flow to the brain. You can get syncopal-induced seizures, so sometimes it could be both, but it could be the underlying syncope as to what's causing the seizures to begin with. As far as trying to differentiate them, what seems to be most helpful is looking at, is there a pre or post change in their behavior? If not, then that should put a red flag that this is an epileptic seizure. With syncope, it's usually brought on by exercise or excitement, but not always. But that list is there for you to try to differentiate between the two as well. As far as autonomic, the one additional that I would put there with syncope is they can urinate. So sometimes they can become so relaxed that their bladder's full enough that they will actually urinate. So it's just something else to keep in mind. And again, all this information is available in the Epileptic Task Force guidelines. Here's our next patient. Happy, playful animal, and then suddenly collapses. So if you want to rewatch the video before seeing what it is, you can. This is a patient with narcolepsy and cataplexy too, because he seems to be completely unconscious. So as far as, again, trying to differentiate between these two, there often is a trigger with narcolepsy and cataplexy, which is usually excitement or eating, which patients are usually excited when they eat. And for narcoleptic patients, once they are awake, they should be normal until the event happens again. Whereas again, with seizures, if they're having pre and post event changes in their behavior, that should put a red flag that this is an epileptic seizure, not something like narcolepsy. So this one, because of the breed, most people know what this is. But imagine if you had a dog that presented doing something like that. You could see how it could potentially be mistaken for a seizure. So this is a goat with fainting goat syndrome, which they're actually not fainting. This isn't a sign of syncope. It's actually a form of myotonia. And so these goats have an abnormality within their chloride channels within their muscle to where they can't regulate an influx of calcium correctly. Usually that gets dampened with a chloride influx, which ends up leading to the stiffness that you're seeing. So there are certain forms of myotonia which can absolutely look like a seizure. So again, imagine that in a dog. Sometimes myasthenia gravis can look like a seizure. So if you can imagine a patient's walking and if they have a myasthenic event to where they collapse, they're hypersalivating, potentially regurgitating, the patient might look distressed, so the behavior might seem abnormal. I've definitely had patients with myasthenia present with the history that the owner thinks that they're having seizures. And again, if a patient is abnormal before or after the event, then that should paint a red flag that it's an epileptic seizure. But you can see how there's other differences as well. This next one will seem obvious to you, but it's probably the one that I've had owners confuse most commonly. But this is a patient with vestibular signs. So again, you might look at this and say, I would never think that's a seizure, which is good, but an owner might bring a patient into you saying that they think their dog is having a seizure, that it's been having a seizure for the last 2 hours, which you'll immediately be concerned. You'll look at the patient and then say, okay, this is not a seizure, this is vestibular disease, and you won't give diazepam because diazepam often makes their vestibular signs even worse, at least for a short period of time. So I'll just briefly put up this so you can have that information. But again, usually when you look at the patient, it's going to be pretty obvious. Here's a young pug that's been having these episodes intermittently, anywhere from 2 to 4 times a month, if I remember correctly. They seem to be sporadic. There's no known trigger. So as you're watching this patient, you can definitely tell that the limb movement is abnormal, that the patient overall seems alert, and his mentation and overall behavior seems pretty appropriate for a patient that's having these weird episodes. So is it possible this could be a focal epileptic seizure? Yes. The other possibility, it's what's known as paroxysmal dyskinesia, which is just an umbrella term for movement disorders. There's a long list of different movement disorders. They're not very common in dogs. The one that's been best documented is within border terriers, and it's actually related to a gluten sensitivity. And there's a couple papers on it that you can look up for anyone interested. But paroxysmal dyskinesias are only involving the motor system, so it's not going to affect behavior. And they should not have pre or post event changes, and they should never have autonomic signs. So if there's any autonomic involvement, it is not paroxysmal dyskinesia. Again, the movements themselves can look very similar to a focal epileptic seizure, and we cannot rule that out in this patient, but paroxysmal dyskinesia should be on your differential list. And then this will be the last patient. So again, think about this patient's behavior. How are they acting? What's their mentation like? What are movements that you're seeing? And is there any sort of autonomic disturbance? And so this was a patient with idiopathic head tremors. And this is just a list of how to compare the two. So that's all I have for you. If you have any questions, definitely let me know. Shoot me an email, and I'll see you in the clinic.